The comedian Louis C.K., during one of his performances, started his show with, "Hello, everybody," only to realize that what he said wasn't entirely accurate. Not everyone in the hall was everybody, and even the majority of people are actually outside the hall, in places like China or elsewhere, not inside the venue. Then he goes on to observe that actually, most people are waves. In fact, if you think about it, as humans, we spend the majority of our time dead, far more than we do alive. This thought leads to his conclusion, we are dead people who haven't died yet. In his book Being Mortal, Dr. Atul Gawande, a surgeon and professor at Harvard University, shares a chilling story. He describes performing surgery on a woman in her 60s who had chest and abdominal pain following a colon surgery that led to a ruptured colon, a heart attack, and kidney failure. The medical team attempted to save her through a procedure called colostomy, which involves diverting waste to exit through an opening in the abdomen. After this major surgery, she underwent heart surgery, dialysis, and was placed on a ventilator. Her condition stabilized briefly, only to deteriorate again. Her heart and lungs needed further intervention, requiring a tracheostomy, a tube inserted through the neck to help her breathe. Additionally, gangrene in her left leg necessitated an amputation. With an opening in her abdomen for waste and no chance of eating independently again, she required special care twice daily. Her kidneys had failed entirely, meaning thrice weekly dialysis. Despite all this, the woman had no spouse or children. When Dr. Gawande consulted her siblings about whether to proceed with further treatments, they asked him, "Doctor, is she going to die?" The stark reality, dear viewers, is that she would indeed die. Unfortunately, so will you, and so will I. I know this is unpleasant news, but it's a universal truth. The question is, why does death always have to be unfortunate? Why is it treated as a defeat or failure rather than a natural part of life? Dr. Gawande emphasizes that medical professionals often focus on extending life, even if the quality of that life diminishes severely. For example, in the U.S., the first year after a cancer diagnosis typically costs around $288,000, mostly for tests and treatments. After that, annual expenses drop to $2,000, only to spike again to $90,000 in the patient's final year of life. He shares data from Massachusetts General Hospital, where patients in the final stages of cancer were divided into two groups. One received standard treatments, while the other had additional palliative care. The latter group had specialists who focused on pain relief, emotional and spiritual support, and helping patients set goals, including when to stop aggressive treatments. Surprisingly, these patients lived 25% longer than those who continued aggressive treatments. This aligns with Gawande's argument. If discussions about end-of-life care were treated like an FDA-approved drug, they would be considered life-extending. Yet such discussions remain rare, even though studies show that hospice care often allows patients to live longer and better than intensive treatments. For instance, patients with terminal pancreatic cancer lived 3 weeks longer on average, lung cancer patients 6 weeks longer, and those with heart failure almost 3 months longer when they stopped aggressive treatments and focused on comfort care instead. Quality of life significantly improved for patients and their families, who were less likely to experience depression after their loved one's passing. However, there is a cultural reluctance among doctors to discuss death. In one study, 40% of oncologists admitted to offering treatments they knew would not work, simply to avoid being seen as pessimistic. This optimism often leaves patients unprepared for the realities of their condition. For example, doctors frequently overestimate life expectancy, which can lead to patients and families clinging to false hope. Dr. Susan Block highlights that many patients undergo treatments they don't want because their families insist on them. She asks, whose life is it really? Reflecting on the 1970s war on cancer, chemotherapy was often described as chemical warfare within patients' bodies, leaving them with severe side effects like hair loss, anemia, and even suicidal thoughts. The push to extend life at any cost often prioritizes survival statistics over patient dignity. Yet, as Dr. Gawande and others argue, sometimes a shorter, compassionate life is preferable to a prolonged, painful one. Medicine is increasingly recognizing the importance of palliative care, which aims to ease pain and suffering rather than extend life at all costs. Ultimately, dear viewers, accepting death with dignity and spending one's final days with loved ones might be the braver choice. Everyone has their priorities, and the decision should always rest with the patient. As Gawande emphasizes, doctors need to communicate better, asking patients about their priorities and respecting their wishes. Some may choose aggressive treatment, while others may prefer a peaceful end surrounded by family. Remember, we are all dead people who haven't died yet. It's every person's right to decide how they want to spend the time they have left. Thank you for watching, and I wish you health and happiness. Let's hope none of us ever faces such difficult choices, but if we do, may there always be compassionate care to guide us. If you're watching this on YouTube, don't forget to subscribe to the channel.